Good afternoon. This is Dr. Schminke, and today we're going to be talking about menopause. The subtitle of this talk, as you can see, is Dr. Schminke on taking care of our society's crones. Now, perhaps that term has a negative connotation to you, but the crone is actually an archetypal figure. It's the wise woman, and too often crones are depicted in literature. Menopausal women too often are depicted in literature as disagreeable and ugly, but this is perhaps because at this stage in life, women are such a threat. Their children are raised, they have time to concentrate on other efforts. Often, crones are compelled to make the world a better place for the next generation, and that can be very threatening to the status quo. Or, for the first time, a crone may have an opportunity to care for themselves and heal their own old traumas. This is a powerful time, and we don't talk about it much. And consequently, women come into menopause without a lot of knowledge about what to expect or what's going on. As healthcare providers, we have an opportunity to make a tremendous difference in a woman's life and perspective as she enters this stage of life. These are the objectives that we're going to meet at the end of this PowerPoint. And I don't know how you like to do this, but I actually organize my notes according to the objectives at the beginning of the PowerPoint. And that might be a useful way for you to organize your notes in this course too. Let's get started. Menopause is the complete cessation of menstruation, including all spotting for 1 year. I'm going to repeat this several times in this presentation. Menopause means different things to women of different cultures. In some, it may be seen as a sign of aging and feeling useless in society. In others, it may be a status symbol to have reached this stage in life. I'm going to be telling you everything that you need to know, well, I hope, to get through this module in the next several slides. But there is a video here you can watch if you want to hear somebody else give a succinct description of what menopause is. And I just put it there just because. To begin with, let's talk about the epidemiology of menopause. 2 million women reach menopause every year in the United States. Typically, we are about 52 years of age when natural menopause occurs in this area. There is some variation globally with this number. Many women will live a whole third of their lives after menopause. Please be aware of these increased health risks that are associated with menopause and being post-menopause. We have a significant problem, of course, with overweight and obesity and cardiovascular disease and diabetes in this country. Of course, postmenopausal women are more likely to experience many kinds of cancers, osteoporosis, and we have increased rates of thyroid disease and depression in this population. As women approach the last third of their life, they are undergoing many changes. And I've listed just a few of the kinds of issues and transitions that are happening to people at this stage of their life. This is a time that has the potential for so much growth, psychological growth and development for people who have spent most of their adulthood focused on raising children and perhaps working to support the children, and finally with the empty nest comes an opportunity to focus on yourself or to focus on the broader world and issues that you might be passionate about. One of the critical things, and the reason I have these sort of morbid charts about trajectories of death, really, on the right-hand side of this slide, is because the physical changes that are happening right now in this stage of life, and the opportunities for people to really maximize their wellness, maximize their health now can make a huge difference in whether they end up having a very high quality of life for as long as possible, like you see on the two top graphs here, where that you don't have a curve of decline until a very precipitous drop at the end of life. And that's the kind of quality of life most of us want for the last third of our lives. And so menopause and perimenopause, this is a time to try to get your patient's attention and get them focused on wellness issues, taking care of their body to lead to long-term wellness as they age. This is a very busy slide of definitions. And the one thing I want to point out at the top is that the timing of when this happens for any particular woman is influenced by these many factors that I've listed here and more. Take a look at these, and I suggest you map them out. Slide 13 actually gives you a chart that you could use to map these out, or you'll see that they essentially are mapped out on slide 13. So in your note taking, you might think of creating a timeline for these. You should be very familiar with this chart that describes what's going on with the menstrual cycle. And I want to review it now before we start talking about what happens when this all stops. So the anterior pituitary is going to be producing follicle stimulating hormone every month throughout the woman's reproductive years. That follicle stimulating hormone, or FSH, is telling the ovary to recruit eggs. And then once you have that androgen environment in the ovary converted to an estrogen environment by the developing eggs, you get the luteinizing hormone peaking at mid-cycle due to the estrogen levels and the follicle stimulating hormone levels, and that results in ovulation. After ovulation, the corpus luteum is making progesterone until until lack of pregnancy results in lowered progesterone levels and bleeding. So now that we've reviewed what happens before menopause, let's talk about the physiology of menopause. During perimenopause, the ovary becomes much less responsive to FSH. The pituitary starts putting out huge amounts, and the FSH is large amounts of it, frantically knocking at the door, trying desperately to get in to create a response in the ovary. And FSH levels are going to increase as more and more hormonal force, gets exerted on the ovary to try to bribe it into responding. But estrogen levels decrease as there are fewer and fewer follicles that can be recruited, and progesterone levels fluctuate as corpus luteums produce varying amounts of progesterone because they're not as good a quality of an egg. Perimenopause, which typically lasts about 5 years, is a time when estrogen levels are fluctuating because the bodies become much less sensitive to FSH and LH. And so you're not ovulating regularly, and this lack of regular ovulation can lead to big changes in women's cycles. They can have very irregular periods that can be much longer or shorter or both. And it's a time of exaggerated symptoms of PMS for a lot of people, insomnia, problems with their libido, and fatigue, vaginal dryness, increased mood swings, urinary leakage, or urge incontinence. are all common at this time. And the low levels of estrogen are thinning out the vaginal tissues and leading to decreased moisture and lubrication, both during everyday activities and especially during sex, which can lead to dyspareunia, painful sex. It also increases her risk for vaginal infections and urinary tract infections. The low levels of estrogen are also leading to cardiovascular changes, as there are both vasoconstrictive and vasodilatory effects of fluctuating and ever decreasing levels of estrogen. There's explanation of this in the notes in a little more detail if you're interested. But this can lead to numbness, dizziness, and most especially to increases in headaches. And people with menstrual migraines find that they can be much more debilitating now. We do sometimes treat these women with birth control pills or progesterone cream, especially for these symptoms. Over time, in spite of all of this FSH pounding on the doors of the ovary, eventually you have fewer and fewer follicles until there are no follicles that ever develop ever again. And at that point, FSH levels and LH levels become persistently elevated. Estradiol levels stabilize at 10 to 20 picograms per milliliter. And these are things that used to vary dramatically. Remember that picture of the physiology of ovulation and how these hormones moved around? They don't do that anymore. They stay persistently high, and over time it's as if your ovaries kind of shrivel up into being like raisin-like organs. I'm kidding a little bit, but that is something like what happens to them. Testosterone levels also remain stable at this point, and it creates a relative androgen deficiency at this point. And these hormonal changes are responsible for the symptoms that women have at menopause. Those symptoms I just referred to are listed on this slide on the left-hand side here and on the right-hand side in this picture. And here we also see that this is a time when you have risk of cardiovascular disease increasing dramatically. And I would say that for most people, it's the cardiovascular risk factors and then all of their genitourinary symptoms that we have to address that are the biggest issues. Osteoporosis, however, bone loss, as the bones become more and more fragile, that's another area that we have to pay attention to. Once upon a time, I spent 8 minutes describing this slide. I'm not going to do that for you. I'm going to refer you to the notes below and let you consider how, just look at this slide and figure out what here can help you understand what is happening during the menopausal transition into postmenopause. We can talk about this in class if you'd like. Your patients will want to know, is this menopause? Well, it's important that we explain to them that this is a retrospective diagnosis. We can't tell you if it's been 8 months or 9 months since your last period. We can't tell you if you're in menopause. It's not until you've hit 12 complete months. As I said earlier, we do not do hormonal testing to diagnose menopause. It's not useful. You can see the changes we had in that table that I showed you earlier, the straw table, that can help us figure out where you might be in your reproductive lifespan. And that might be helpful to even share that with women and say, you see, here you can still be in the late reproductive stage and have some changes in your period, but they're not significant enough for us to think of it as being perimenopausal yet. And yes, you are often going to have symptoms that our society labels menopausal symptoms, the vasomotor symptoms, vaginal dryness, that these can happen in the perimenopausal period, and it still doesn't mean you have are menopausal. I know that's confusing. So there are some things that you want to make sure to evaluate women for when they come in with menopausal symptoms. Of course, in this country, with our high rates of diabetes, you absolutely need to evaluate for diabetes. You want to evaluate for thyroid disease and depression and anxiety. And of course, as I was just saying, sleep issues. Be aware that medications, alcohol, or drug use can cause similar vasomotor symptoms to those that we see in perimenopause and menopause. So you want to make sure you're not missing something that might be adjustable to help improve their symptoms. The most common issues that women are going to bring to you related to menopause are going to be complaints of hot flashes. Up to 80% of women experience them. And then followed this by vaginal dryness or dyspareunia, painful intercourse. But when you're taking their health histories, if you remember to ask about these issues that are listed on the right, you will discover that these women are often experiencing disturbed sleep, either trouble getting to sleep, early waking, or both. And in addition, it's a very common thing in this developmental stage for women to be experiencing either or both anxiety and situational low self-esteem. And the physiology of those two issues is not very clear to me, but if you care for women in this age group, you're going to see it again and again. In the next PowerPoint on non-pharmacological and pharmacological treatment of menopausal symptoms, we're going to be looking at what we can offer women who come to us with these problems. I said earlier that hot flashes are the main thing that women are going to come complaining to you about related to menopause. And this is primarily related to estrogen, to a deficiency of estrogen. But if that was the entire answer, we would be able to fix it just by giving them estrogen supplements. And it does not completely eliminate hot flashes for a lot of women, although it does certainly reduce the frequency and the severity of the hot flash. I'll tell you that the first time and the most severe hot flash I ever had was on a day when I was in my PhD program. So I'm letting you know just how very old I am now that I did my PhD in the middle of menopause, and I was on the campus in Bethesda, Maryland at the National Institute of Health, and I had a presentation to give there at a meeting. And I walked into the building, and it was like, as I walked into the building, it was 110 degrees in the building, I was certain. And fire, heat, it was like this heat wave, a tsunami of heat swept up through from my abdomen, up my chest, out my arms, my head. I was on fire. And I ran to the bathroom, and the first bathroom I could find, and I locked myself inside a stall, and I proceeded to simply strip because I was covered in sweat at this point. And I mean, it was not a difficult walk to get into the building, but there I was, and I just stood there fanning myself with papers I'd pulled out of my briefcase, fanning myself furiously, and then taking toilet paper, because I'm in a bathroom stall, and mopping myself before I put my clothes back on, because I didn't want my clothes to be sopping wet. And it took just a few minutes. It completely passed. I was fine, and I sat down and I thought, well, I guess I can't deny that welcome to menopause. So, and that I'm fortunate that didn't happen to me hundreds of times a day, but I've had patients who will report having that experience up to 20 times a day, and that's pretty debilitating, isn't it? You should always consider that with these patients, They might have a medical condition. It could be a thyroid issue, and there are hypothalamic and pituitary cancers that can cause hot flashes. So if the picture does not fit with menopause, and particularly if they're getting worse and worse, and the woman's menstruating regularly, although that also could be thrown off by the tumor, but just know that it's very rare, but there are other things that can cause hot flashes like this. Up until now in this PowerPoint, I've been using the old terminology and talking about vulvovaginal atrophy as if that is the diagnosis that we use. Now, vulvovaginal atrophy is a physical sign, but it is a part of a syndrome that we've identified. It was identified in 2013. We call it the genitourinary syndrome of menopause, and it encompasses these genital symptoms, sexual symptoms, and urinary symptoms that are all impairing someone's experience of life and their sexual and daily function in some cases. In a recent large cohort survey of people in Western populations, they found that 45 to 63% of postmenopausal women reported that they'd experienced some kind of vulvovaginal symptom. And these symptoms are directly related to the reduced circulating estrogen that you have after menopause. Estrogen receptors are present in all of these tissues, in the musculature of the pelvic floor, in the endopelvic fascia, in the urethra, the bladder, the vulva, the vagina, during all of this. And their levels decline with menopause and may be restored by treating with estrogen, which we'll talk more about in the next PowerPoint. But as a result of this estrogen deficiency after menopause, there are all of these anatomic and histologic changes that occur in these tissues, including a reduction in the content of collagen and hyaluronic acid and in levels of elastin, and that's what causes the thinning of the epithelium and alterations in the functioning of the smooth muscle cells. There's an increase in the density of the connective tissue, but the epithelium is less dense, and there are fewer blood vessels. These changes all reduce the elasticity of these tissues. They increase the vulvovaginal pH and lead to changes in the vaginal flora. They diminish lubrication and increase vulnerability to physical trauma from activities that are normal, like sexual intercourse. I keep referring to architectural changes of the vulva, and what we're talking about is vaginal atrophy or vulvovaginal atrophy. And these are some pictures of what that looks like. You lose the rugae, you lose all the folds, and not every woman is going to have this level of change, thank goodness, but many women do, and topical estrogen can definitely help with this, help restore some of it, but this is not at all uncommon, including down here on the lower left-hand side. This dark red area in the middle here is actually a prolapsed urethra, and I see that fairly often, actually, in menopausal women, that you get this protruding urethra that is very, very tender and sensitive for some women when they're having sex. So it can be problematic for some women. To recap what we've been talking about in this PowerPoint, I want to make sure that you are clear about the physiology of perimenopause and menopause, and that you can describe common physical complaints and the increased health risks that are associated with menopause. And finally, that you can feel comfortable discussing the presentation, the variation, because mileage varies with menopausal symptoms. There are women who are going to say, I breezed through it, I didn't even notice it. And there are women who are going to find the symptoms crippling. And so that you can recognize those variations, that you can understand the differential diagnoses that need to be considered, and now you have an understanding of what it is that we need to treat. In the next PowerPoint, we will talk about how to treat menopausal symptoms.